So, good morning, one and all. Welcome to this session on pediatric potpourri, a comprehensive pediatric ophthalmology in a nutshell. In this program, we plan to comprehensively speak about the salient features of pediatric ophthalmology. Now, without much ado, let us go into the talks. First of all, let me call Dr. Chaitanya Warrior to speak on the topic, Can this child see refraction and glass prescription in children? Chaitanya is a consultant in Chaitanya Eye Hospital.
Good morning, one and all. I would like to thank Dr. Divya ma'am for making me part of this IC. I will start with my refraction in pediatric population. As you all know, the pediatric population requires a regular assessment of their vision and ocular examination due to their unique visual needs. Different types of people will be coming to our OPD for different sets of checkup as for a part of normal checkup or for sibling screening as part of referral or detected defective vision or as a special child. Any patient who is coming to OPD, the two questions are very important. The parents will be asking, is my child vision okay? Can my child see? Or the next will be, do my child need glasses? There will be a tug of war between these two questions and we need to answer it properly. Can my child see is a very difficult question to answer. For that we need to go through the development of vision and also we need to do a proper refraction in pediatric population that should be very fast and accurate. Sometimes our refraction room will be quite a first picture or will be like the second picture. Timing of refraction at least before going to school and the children who are symptomatic need early intervention. And the refraction will be like a stepwise algorithmic pattern in adults and older children. But for younger one, it should be a tailored pattern and we need to use different type of pediatric charts. Cycloplegic refraction is a must and additional test including full thorough ocular examination is needed. So pearl number 1 is a detailed history, thorough examination and complete cycloplegic refraction is must for pediatric refraction. When and whether to prescribe the glasses is the next important question. Now we completed the cycloplegic refraction. We are having the retinoscopic reading and the refractive acceptance. So when we tell the parents that your child need glass, the questions will be, they will be bombarding questions like, really my child need glass or can wait doctor? How long my child need to use glasses? Is this refractive error will get corrected with glasses? Or is there any other treatment, alternative treatment other than glass? And the next other question will be, why my child's power is progressing even with glass? All these questions we need to answer. For that, we need to go through emmetropization and different type of refractive errors based on age-wise approach that we will discuss based on some cases. See, a 10-year-old child with compliance of defective vision came to OPD on examination. Uncorrected visual acuity was 6/18, improving to 6/6 with minus 2.5 diopter sphere. Rest ocular examination was normal. On cycloplegic refraction, it was minus 2.5 diopter sphere. So there is no doubt we need to prescribe the glass. But the most important thing in this child is 10-year-old in a progressive myopic age group. So we need to prescribe glass, also educate them regarding progressive myopia and environmental factors of progressive myopia. Also ensure follow-up, and if there is progression, we need to go for progressive myopia treatment. Coming to another 1.5-year-old child who came for ROP screening. Vision was mild myopic. Do we need to prescribe glass? No, we can wait. But we need to explain the parents regarding the refractive error and ensure regular follow-up. Same age child for ROP follow-up, but here the myopic reading was high myopic. So definitely we need glasses. Don't hesitate. We need to prescribe glass. Regular follow-up should be ensured. So pearl number 2, we need to prescribe glasses, explain the reason. Also, we need to explain chances of progression and we need to ensure the follow-up and also teach the parents method to halt myopic progression. Another 2-year-old child with compliance of squinting. On evaluation, it was right XT, alternating XT, but left eye was dominant. Cycloplegic refraction revealed high myopic reading. Here, the thing is, we need to prescribe full correction. Another one, 13-year-old child was referred to me for treatment of amblyopia. She was using glass for last 5 years, but the BCVA in the right eye was only CF 5 meter. Why it is amblyopic? Because she was unilateral high myopic. She was given a under-corrected glass in the right eye. So we need to prescribe full correction. Pearl number 3 is, do not hesitate to prescribe full myopic correction, especially in high myopes or in unilateral high refractive errors. Coming to a 12-year-old girl with compliance of defective vision, uncorrected visual acuity was CF 3 meter, improving to 6.6 with minus 7 diopter sphere. On dilated cycloplegic refraction, turned out to be normal refraction. This is a case of pseudomyopia. So my pearl number 4 is, any form of refractive error, do a proper cycloplegic refraction before prescribing glasses, especially in first time, if there is progression of power, change of axis, or any associated eye strain with glasses. Coming to few hypermetropic cases, a 3-year-old child with squinting for few months. There is alternate esotropia. Cycloplegic refraction with atropine is a must. Reveal high plus power. This is a case of accommodative esotropia. Need full power glass prescription and also amblyopic treatment. Another 10-year-old girl noticed defective vision during school screening. Uncorrected visual acuity was 6/24, improving to 6.9 in right eye and 6.18 in the left eye. It is a unilateral high hypermetropia. She needs full correction in the left eye and amblyopic therapy also. Pearl number 5. Hypermetropic refractive error should be prescribed considering the best corrected visual acuity, squinting, and amblyopia. Pearl number 6. Don't hesitate to reduce hypermetropic power after 8 to 10 years of age in orthophoric children, and also accommodative esotropes in correlation with their BCVA and squint. A 3-year-old child with Down syndrome, for ocular evaluation, dry retinoscopy was normal, but their dynamic retinoscopy revealed poor accommodation. Cycloplegic refraction also normal, but due to poor accommodation, we can prescribe a plus power. So pearl number 7, not only refractive error, but also other factors like issues of accommodation, convergence, that lead to eye strain or asthenopia, and defective near vision should also be considered while prescribing glasses. Coming to few astigmatic cases, a 6-year-old child came with blurring of vision with full cylindrical power. She was not improving to 612. Here the confusion will be whether to prescribe full power or not. Definitely it is a case of meridional amblyopia. It will improve only with full cylindrical power. And another 4-year-old child came to OPD for treatment of injury with it is a case of hyphema. But on refraction, there is a cylindrical power. She need to be evaluated after her acute state is okay. So pearl number 8, if there is any refractive error which is associated with amblyopia or significant for age-related visual needs, or there is an effect on strabismus, we need to prescribe the glasses even if there is no subjective response. And pearl number 9, special attention to be given to amblyogenic risk factors, anisometropic risk factors, aphakia, pseudophakia, and subluxated lens. Also special situations like nystagmus, cortical visual impairment, syndromic children, autistic or hyperactive, and neurological issue to be considered. A 12-year-old girl was referred for treatment of defective vision. Uncorrected visual acuity was 6/60 and counting fingers 4 meters, not improving. And the reason was large amplitude rotatory nystagmus. Cycloplegic refraction was normal. So here we need to manage with low vision device, and we need to explain it is not related to the refractive error. The cause is the nystagmus. Another 8-year-old child referred for treatment of defective vision. The child was a preterm, long neonatal ICU, and vision was not improving beyond 612. There is no refractive error, but a fundus minimal pallor. There was extensive PVL changes was there. Here we need to manage the cortical visual impairment. Vision therapy, addictive devices or low vision device is the treatment. Another 7-year-old was referred for treatment of defective vision. The child was autistic. Also, he underwent treatment for large arachnoid cyst. Here, the vision was not improving beyond 6/24. Fundus pallor and also large amplitude nystagmus was there. MRI, extensive encapsulomyelitic changes. On cycloplegic reading, there is a minimal cylindrical power is there. Here also we need to prescribe minimal cylindrical power, ensure follow-up, and vision therapy and addictive devices or low vision devices the other management. So pearl number 10, low vision device, vision therapy and developmental therapy should be considered in required cases along with the refractive error correction. These are all the general guidelines. We need to be individualized based on case-based treatment, and follow-up should be ensured. So spectacle prescribing is an art considering the refractive status and visual acuity along with the global evaluation of child. Thank you.
Thank you, Dr. Chaitanya. That was a very comprehensive talk. Now, may I call upon Dr. Samyukta Sadashivan, Assistant Professor of Ophthalmology at Government Medical College, Thrissur. She'll be speaking about the enigma of the squinting eye decoded.
Together for the first time. Hope to make it a good one. Okay. Uh, Moving on from where Chaitanya stopped, enigma of the squinting eye. So to decode strabismus, the process essentially involves identifying the exact nature and cause of the ocular misalignment. So we need to characterize and measure the deviation, assess binocular single vision, and then establish a strabismus diagnosis. So due importance has to be given to the history taking part. Exact the presenting complaint, ask about the time of onset, duration, whether acute or not, frequency, constant or intermittent, progression, variation, presence of associated diplopia, screen time duration in the current scenario, history of patching, spectacles, prior ocular surgery, sinus surgery, neurosurgery, and of course birth and development history. So we see that the child, so as we take a history, give attention to the general demeanor of the child, the visual behavior, mobility, and the family social dynamics. We initiate workup with age-appropriate methods of visual acuity assessment, followed by sensory evaluation to assess binocularity and stereopsis, and then motor evaluation, again fundus evaluation and cycloplegic refraction follow. Always imperative to take a FAT scan, familial album tomography scan. See here the child has been maintaining the constant anomalous head posture right from her infancy into childhood. These are the different tests we have at our disposal for age-appropriate methods of visual acuity assessment. Observe the head posture, look for any head tilt, face turn, chin lift or depression, facial asymmetry, proptosis, ptosis, nystagmus, mongoloid or anti-mongoloid slant. Rule out pseudo deviations, pseudo ESO you get in epicanthus or in negative angle kappa, pseudo EXO in hypertelorism, and also look for pseudo hypotropia which you may get in ptosis. This is the goniometer, a very useful instrument to quantify the anomalous head posture. If you don't have it, you can even make use of 2 scales and a protractor. Very important to document the measurements prior to surgery, especially when anomalous head posture is an indication for performing surgery. Go ahead with assessment of ocular rotations, versions followed by ductions. Any asymmetry in versions means check the ductions in detail. So a thoroughly performed ocular rotation assessment will give you an idea about the commitance of the deviation. And we have these useful apps like 9Gaze app which helps in on-the-spot photographic documentation of the ocular deviation in 9-gaze position. So when you get such a picture, focus at the central image, identify the primary position ocular deviation, and then you go about serially from one end to the other to assess ocular deviation in the different gaze positions. Simultaneously give due attention to peculiar movements like upshoots or downshoots or coexistent features like globe retraction, narrowing or widening of the palpebral fissure. Cross fixation, a frequent accompaniment of infantile esotropia, is frequently mistaken for a limitation of abduction. You can actually demonstrate normal abduction by patching one eye and forcing fixation to a favored target. You can actually demonstrate abduction in this way. and go ahead with the documentation of extraocular movements. While grading overactions and underactions to rule out oblique dysfunction, ensure that the patient fixates with the abducting eye so that the adducting eye is free to execute its overactions or underactions. This is the Hirschberg's test. We know it is a basic screening test which helps to assess the primary position ocular deviation. It requires the patient to be fixating at the central spotlight. At this juncture, let's distinguish angle kappa from tropia. Angle kappa means it is not a true strabismus and it is not related to the other eye also. So here, the light reflex is displaced from the center in monoocular viewing also. How do you confirm it? You do a cover-uncover test and you see that there is no refixation shift on doing cover-uncover test. So cover test requires a cooperative patient with sufficient vision and central fixation. In manifest deviation, you do a direct cover test, occlude one eye, observe the refixation shift of the other eye. If you don't get any shift, think of orthophoria, gross eccentric fixation, or maybe the patient has no vision at all. Cover-uncover test becomes important in latent squintophoria. Here we interrupt fusion and we observe the movement of the eye under cover. Should observe not only the movement, you see specifically the speed of the movement also, which gives an idea about the recovery and control over the phoria. Alternate cover test fully dissociates binocular fusion, determines the full amount of deviation, phoria, tropia together. And thoroughly performed means it gives an idea about the fixation preferences or ocular dominance. So how to quantify your deviation? You have the prisms at your disposal and the prism cover tests mean a lot. In large deviations, it is imperative not to stack prisms of the same orientation in front of one eye. That leads to underestimation of the angle size. So in large deviations, you can split the prisms between the two eyes. However, it is acceptable to stack a vertical prism in front of the horizontal prism. So if you observe the image closely, you can see that the displacement of the image is grossly varied in the prism below as compared to the stacked prisms above. And we can refer to this Guyton's table to correctly quantify the total amount of deviation. Here, see, 40 plus 40 is 90 and not 80. Prism alternate cover test is the ultimate method which we resort to calculate the surgical dosage. It has to be done for near and distance in the anomalous head posture as well as in the forced corrected head posture. And when it comes to a comitant deviation, it is alright to place the prism in front of either eye and perform the prism alternate cover test. In incomitant deviations, you need to do this with the prism first placed in front of the right eye, then in front of the left eye, and thereby you assess the primary and secondary deviations. Do not miss the patterns. And in uncooperative patients or in sensory strabismus, we have the Krimsky test. It has to be done in the near as well as in the primary position. Disadvantage is that it underestimates the angle in large deviations. It's basically a glorified Hirschberg's test with the prism. When the prism is placed in front of the fixating eye, it is the modified Krimsky test. And for cyclodeviations, we have the Maddox double rod test. Older children can also cooperate for this. We place the Maddox rods in front of the eyes in the trial frame in the vertically oriented position. And the spotlight is shown. The patient is instructed to observe the positioning of the line images, which will be seen as horizontal line images. If there is no cyclodeviation, both the line images will be parallel to each other. Suppose there is an oblique dysfunction, one image will be tilted with regard to the other, and the patient has to rotate the Maddox rod until the line images come to lie parallel to each other. Disadvantage is that it does not localize the abnormal eye, and you have to club it with a fundus examination for correct assessment of torsion. Sensory examination follows. You have the Worth 4 dot test. It has to be done for both distance and near. Red-green goggles are worn by the patient, and these are the different responses. With Bagolini striated glasses, each eye perceives an oblique line of light perpendicular to that viewed by the other eye. Assesses BSV. These are the different tests for stereopsis which we have at our disposal. Stereopsis for distance need to be measured too. You have the Randot stereo test for the same. So finally, it is cycloplegic refraction that is mandatory, because maximizing vision by dispensing the proper cycloplegic refraction itself provides for good control of the deviation. So up to 5 years, you can make use of atropine eye ointment for cyclorefraction. After 5, cyclopentalate and hometropine can be used. Cyclopentalate, beware that in some children it is associated with neurological symptoms like transient rise in blood pressure. So lower strength should be preferred. This is followed by posterior segment examination. Especially look for fundus pathology like a dragon macularis in this case, which is a neuropathy sequelae. Fundus torsion should not be forgotten. Also remember to think about eccentric fixation. So this is how you grade fundus torsion. This is the indirect fundus view. So basically, if you do a thorough basic squint evaluation, that itself will enhance the patient outcomes. Thank you.
Thank you, Dr. Samyukta. That was a very extensive talk, taking us through the unknown. Now we'll show some light on the white reflex unraveled by Dr. Divya. Over to you.
Good morning, everybody. First of all, let me thank KSOS for giving us this opportunity to present this topic on pediatric potpourri. Excuse me. So today I will be discussing about the white reflex unraveled, congenital cataract and more. The white reflex is an ominous sign because it is not only a sight-threatening condition, but also at times it can become a life-threatening condition. So understanding the importance of this assessment of red reflex, the American Academy of Pediatrics has made it mandatory to assess red reflex in infants and neonates as a routine practice. So what are the abnormalities that you see? A symmetric red reflex is what you always like, but you can also have a dimmer reflex, a white reflex, opacities in the media, as well as the Bruckner test, which is the deviated eye showing a brighter reflex. So what are the causes of this leukocoria? One is congenital cataract. You can also have this ominous retinoblastoma, Cott's disease, coloboma of the choroid and the optic nerve head. You also have a group of retinal conditions: familial exudative vitreoretinopathy, persistent fetal vasculature, retinal detachment, ROP, toxocariasis. Today I will be focusing mainly on congenital cataract. The rest of the retinal conditions, a few of it will be described by Dr. Danya. So pediatric cataract, the incidence is about 3.6 per 10,000 per year, and the median prevalence is 1.03 per 10,000 children, and it accounts for about 15% of pediatric blindness, of which 27% are associated with ocular anomalies and 22% with systemic anomalies. What is the etiology? You can have the most common is the idiopathic cause, then maternal factors like torch infection, drugs, radiation, malnutrition, fetal factors like metabolic disorders, deficient oxygenation, birth trauma, and congenital anomalies. And also the hereditary factors account for 25%, of which 75% is autosomal dominant. Morphological types, it can present from total cataract to affecting any part of the lens. These are the pictures that are taken from the Rupal Trivedi textbook. You can see that it has got a very varied presentation. But the importance of morphology is that sometimes the morphology points to the underlying systemic pathology. For example, the spoke-like cataract would point to a Fabry's disease, macular and diabetes mellitus, multicolored flux in hypoparathyroidism, sunflower cataract in Wilson's, and thin disciform in Loeys syndrome. But not all cataracts should ring the alarm sign, because sometimes you get what is called as a visually insignificant cataract. Maybe when you have got a very good red reflex, less than 3 mm of the central lens opacity, when the fundus details are very clear, visual acuity better than 6/12, all those things you can have a conservative and a follow-up management. Now, how do you evaluate a pediatric cataract? You begin with a general examination, then you go to the investigations, where you focus on torch, IgG, IgM, VDRL, then urine for reducing substances, urine for amino acids. And in complicated cases where you're having a doubt about the diagnosis, maybe you can do an examination under anesthesia for this leukocoria to identify the cause. But in routine cataract cases, axial length, keratometry, IOP, corneal diameter, all will be done along as the initial test that you do for the general anesthesia. Now let us see 3 cases. The first is a 3-year-old child with bilateral developmental cataract. You go by the routine clinical examination. What is more striking in this particular case is that there is a very high risk of amblyopia, because for 3 years, over the 3 years, he was having the stimulus deprivation. And post-surgery, there is always, as in any child, there is a risk of visual access opacification. So what is the surgery that we do? We do a lens aspiration with primary posterior capsular access and anterior vitrectomy and intraocular lens implantation under general anesthesia. Now, IOL power calculation in children is a very challenging one, not only because they're very uncooperative, but even under general anesthesia, you may not be able to get the correct axis and the alignment. Then, since the eyeball is very small, you can have the errors very much exaggerated, and the post-op myopic shift also adds on to the problem. Usually, you use a handheld keratometer and a portable A-scan and the IOL formulas to identify the intraocular lens power. But what is important is that the child's eye is growing. So we tend to undercorrect the lens power that we are going to put for the child, because you want the child to grow into the power that you are planning to put. For example, for this 3-year-old child that we saw, if the intraocular lens power calculation gives you a 28, maybe you will undercorrect it by 4 and you put in a plus 24 diopters. The surgery is complicated because of the reduced scleral rigidity and corneal rigidity, more inflammation after surgery, develop reopacification of the visual axis, and there is always a risk of amblyopia. So one of the most crucial steps is the anterior capsular access. I've taken this video of Dr. Ramesh Kekunia from CyberSci. So this pediatric capsule being very elastic, we have to stain it so that the elasticity is slightly reduced as well as the clarity is improved. And you can see how you have to pull it perpendicular to the direction that you want the rexus to form, because otherwise it tends to run to the periphery. An equally important step is the posterior primary capsular rexus. So this is mandatory because if you don't do a primary posterior capsular rexus, there is 100% chance of visual axis opacification because of the lens epithelial cell growth. Not only that, you have to also do a anterior vitrectomy associated, because the anterior vitreous face can act as a scaffold for the lens epithelial cells to grow into that. So it is mandatory that less than 5-year-old you do a primary posterior capsular rexus with anterior vitrectomy. 5 to 7 years maybe just a primary posterior capsular rexus may do good. Now suturing, yes, there is no other option because there can be fish mouthing of the wound due to pure scleral rigidity. The child can rub the eyes. Post-op assessment of the shallowness of the chamber may be very difficult and you may have to go in for another GA. So considering all these factors, you must really suture. The post-op complications of increased inflammatory response, secondary glaucoma, visual axis opacification, IOL capture, suture-related complications all should be kept in mind. So you follow up with vision and refraction, intraocular pressure, ocular alignment, and you give the glasses. So for a 3-year-old, you will be giving a executive bifocals, whereas in 1 to 2 to 3 years, what you do is you do the refraction and add the near vision plus 3. Now this is a second case where it is a 3-month-old child with bilateral cataract. So the importance is that in such conditions, surgery should be done at 6 to 8 weeks to get the maximum visual outcome. And the surgery that is done is lens aspiration with primary posterior capsular rexus plus anterior vitrectomy. And you follow up the child and then you give them glasses with some add for the near vision. Now this is the third case. It is a 6-month-old child with a unilateral cataract. When it is a unilateral cataract, ocular causes are more likely and the systemic conditions underlying are rare. So you have to watch for PHPV, posterior lenticonus, trauma, anterior segment dysgenesis, and other posterior segment pathology. The critical period for surgery would be in 4 to 6 weeks. Now comes a $1 million question: to place an IOA or not to place an intraocular lens. So the infant aphakia treatment trial was done to find a solution to this problem. So they took 114 children, they divided them into 2 groups. In one group, it was just lensectomy with contact lens and patching. In the other group, it was lens aspiration, PPC, anterior vitrectomy, and the primary intraocular lens implantation was done. They followed up them for 1 year and up to 5 years, where visual acuity, complications, post-op adverse effects, additional intraocular surgery, stereo acuity, glaucoma rate, and adherence to patching was studied. So what did they find? They found that at 4.5 years, there was no visual acuity benefit to intraocular lens implantation. But there was 1.5-fold increase in post-operative adverse effects and 3.5-fold increase in additional intraocular operations when an IOL is placed. So what is the take-home message? Maybe in less than 7 months, it is better to leave the eye aphakic and focus with contact lenses. IOL implantation is recommended after 1 year of age, and 7 months to 1 year, the decision can be individualized. So the take-home message is, for bilateral congenital cataract, the ideal time for surgery is 6 to 8 weeks of birth. Unilateral, it is 4 to 6 weeks of birth. Lens aspiration with primary posterior capsulorhexis and anterior vitrectomy is what we advocate, and IOL placement usually after 1 year of age. But what we need to keep in mind is that this cataract surgery is just the beginning of this very long journey. So we have to follow up the child for many, many years for a better visual outcome. Thank you all for the patient listening. Thank you so much.
Thank you, Divya. That was a wonderful talk. Now we'll listen to Dr. Navina about the watering eyes.
So, good morning all. Thank you, Divya, and thank you, KSOS, for giving me this opportunity. So, today I will be dealing with the watering eyes, CNLDO, and beyond. So, as you know, the tear system is composed of two components, the secretory system and the drainage system. True epiphora refers to watering due to obstruction in the lacrimal outflow pathway, whereas hyperlacrimation is overproduction of tears. Any disorder that can irritate the cornea will lead to epiphora. This can be considered as pseudoepiphora. The causes include epiblepharon, congenital entropion, congenital glaucoma, allergic eye disease, keratitis, and uveitis. Embryologically, the lacrimal duct starts development at the age of 3 to 5 weeks of gestation. Canalization starts by 3 months of gestation and complete connection to nose by 8 months of gestation. So the fusion of maxillary process with the lateral nasal process results in the formation of nasolacrimal sulcus. The ectoderm separates from the surface and forms a solid epithelial coat which proliferates in the craniocaudal direction and later on undergoes apoptosis to form the lumen. Coming to the topic per se, CNLDO. In children, the most common cause of epiphora is congenital nasolacrimal duct obstruction, accounting for 20 to 30% of newborn. A typical cause of CNLDO is due to persistence of Hasner's membrane. Other causes may include bony abnormalities or narrowing of distal end of NLD. These are some of the syndromic associations of CNLDO. History taking is very important in case of pediatric epiphora, and this should include the onset, frequency, type, intermittency, and laterality of the symptoms, and also any history of previous interventions. History of exacerbation during the episodes of upper respiratory infection point towards a functional stenosis, and also rule out any history of trauma to ocular adnexa or nose. Coming to clinical features, epiphora occurs within first 4 weeks of life. The classic clinical triad is epiphora, matting of lashes, and mucopurulent discharge. So the evaluation should include macroscopic examination of the facial skeleton and also rule out any lid malpositions. Special attention to be directed to the sac area to rule out any swelling, skin discoloration or fistulas. Also note increased marginal tear film height. The most important maneuver is Rhoplus, compressing the lacrimal sac just behind the anterior lacrimal crest and expressing the contents out through the punctum. If Rhoplus is positive, a note should be made on the type of the material regurgitated, whether it is mucoid, mucopurulent or bloodstained. A positive test is a confirmatory test for NLD obstruction, and no further diagnostic testing is usually necessary. Another most important test useful in children with epiphora is FDDT or fluorescein dye disappearance test. Here we can instill 2% of fluorescein into the conjunctival cul-de-sac. After 5 minutes, there should not be any detectable fluorescein under blue light illumination. A positive test, or that is the retention of dye, indicates there is a dysfunction in the lacrimal outflow pathway, but it cannot find out the site of obstruction. So another important part of evaluation is ENT examination in the form of anterior rhinoscopy or nasal endoscopy to rule out intranasal pathologies such as intranasal cyst. Rare radiological investigations include lacrimal scintigraphy and CT dacrocystogram. Coming to NLD stenosis, depending upon the degree of stenosis, it can be either relative stenosis due to narrowing, which spontaneously improves as the child grows, or it can be absolute stenosis due to occlusion, or it can be a functional stenosis associated with rhinitis, which will cause nasal mucosal inflammation and subsides as the cold, and it spontaneously disappears as the cold subsides. These are the complications associated with CNLDO. So the most important part of management is conservative, that is massage of lacrimal sac, Krigler massage, hydrostatic pressure over the lacrimal sac area. The goal of massage is to force the fluid down to the NLD and cause the obstruction to open. So method of sac compression. So the parent should hold the baby in one hand with contralateral index or little finger. You have to just compress over the lacrimal sac area just inside the anterior lacrimal crest below the medial canthal tendon. And how frequently? 10 times per session with 4 sessions per day. That means 40 times per day. There is no need for downward stroke. So spontaneous resolution of CNLDO is attributed to the gradual maturation of NLD system, and our aim is to promote this natural resolution by applying gentle pressure over the lacrimal sac area. When performed properly, it plays a key role in reducing surgical interventions. So now the use of topical antibiotics should be minimized, indicated only when there is conjunctivitis or associated dacrocystitis. So the antibiotic eye drops carries the risk of bacterial resistance. A chronic bacterial infection at lacrimal sac level can cause fibrotic remodeling at the level of Hasner's membrane, and it will result in reduced treatment success. Coming to invasive procedures, probing. The timing of probing is always a topic of debate. Some recommend intervention until 1 year of age, whereas others recommend early probing, that is between 6 and 9 months of age, usually advocated in case of mucocele or dacrocele, or if babies are awaiting for any intraocular surgery like cataract surgery. So coming to technique of probing, so the punctum is dilated with a Nettleship punctum dilator. After that, appropriate site Bowman's probe is chosen, and it is passed first through the vertical canaliculae, then slightly give a lateral traction on the lid and pass it to the horizontal canaliculae until we get a hard stop. After that, rotate the probe 90 degree and align it parallel to the supraorbital notch. Then the probe is gently advanced into the nasolacrimal duct downwards, backwards and laterally. Mild popping sensation is felt when the probe penetrates the membrane. These are the different sizes of probe available for different age group, and here you can see as the number of zeros increases, the diameter of probe decreases. So the success rate of probing is reaching up to 90%, and if the symptoms recur, we can do probing after 4 to 6 weeks, and in cases where 2 probing attempts fail, further imaging modalities have to be done. Now, endoscopic assisted nasal probing has improved the success rate of NLD probing, minimizing the complications such as false passage and also nasal mucosal trauma. So with that, the CNLDO can be classified as simple and complex. Simple, the membranous obstruction can be overcome with minimal resistance. Complex can be again divided into incomplete and incomplete. In incomplete, the probe can be retrieved from the nose, and in complete, the probe cannot be passed into the nose. That means it is a bony obstruction. So coming to another invasive procedure, balloon dacroplasty. Here the goal is to dilate the distal part of the NLD using balloons. There are 2 sizes of balloons, 2 mm and 3 mm. So here the balloon is having 2 markings, that is 10 mm and 15 mm. So the balloon catheter is lubricated and passed into the lacrimal system until the 15 mm marks coincides with the upper punctum. Then 2 cycles of balloon inflation and deflation can be performed. The first cycle 8 atmosphere pressure of 90 seconds, followed by second cycle 8 atmosphere pressure of 60 seconds. Then the probe can be withdrawn to 10 mm mark, and again this is done to dilate the NLD. Now coming to silicone intubation. Silicone intubation is another invasive procedure, but the problem here is that the babies will need a second surgery for the removal of the tube. The last resort is dacrocystorhinostomy, especially useful in case of bony obstruction and complex cases. So it can be done either externally or endonasal wise. External, preferably once the facial development is complete, and this reported success rates are reaching up to 96%. Endoscopic endonasal DCR has got advantage of like assessing the intranasal abnormalities as well, and precise visualization and management of obstruction. Now a few words about dacroendoscopy. It is a procedure using microendoscopic technique to visualize the entire system, starting from the puncta to the inferior meatus. So we can accurately assess the type of inflammation, location of fibrotic tissues, as well as recanalization is possible. Now, some unusual congenital lacrimal disorders that can lead to epiphora. One is punctal agenesis. So here the treatment is conjunctivo-dacrocystorhinostomy. Another is incomplete punctal canalization, which refers to punctal dystenesis with membranes. So here puncturing the membrane with a punctum dilator will treat this condition. Then comes the dacrocystocele or amniotocele. So this presents as a bluish mass just below the medial canthus immediately after birth. So if there is no infection and no respiratory distress, it can be treated conservatively. If there is infection and respiratory distress, endoscopic removal of the cyst and probing is needed. So to conclude, knowledge of the various causes of epiphora as well as their therapeutic approaches enables effective treatment and delivers individualized care for pediatric population. Thank you.
Thank you, Dr. Navina, for that very good presentation. Now let me invite Dr. Dhanya R.S., Associate Professor of Ophthalmology, Alapura Government Medical College, as she demystifies pediatric retinal mysteries, ROP and beyond.
Good morning, one and all. Thank you, Divya, for this opportunity. So today morning we'll discuss about a handful of pediatric retinal conditions. It's not going to be a very elaborate talk because there are so many conditions which are very familiar for all of us. So there are a handful of situations which you see when you are evaluating a child, a baby, a newborn. First of all, we'll go to the most important thing, that is the retinopathy of prematurity. As you all know, it is a vasoproliferative disorder of the immature retina, and the abnormal vessels will grow, and it may lead to, if not intervened in time, it will lead to retinal detachment and blindness. So this is a very important slide. I want you to listen carefully, because in the normal intrauterine growth, there is a natural hypoxia which is responsible for the physiological normal vessel growth in utero. Now what happens when there is a preterm delivery? There is an arrest, and immediately there is a phase 1, that is a hyperoxic phase, that is the baby is exposed to the atmospheric oxygen, and also during the golden hour there will be a resuscitation by the neonatologist, which will also produces immediate hyperoxia, which will suppress the VEGF, arrest the vessel growth. That is a phase 1. And second phase is a phase of hypoxia, where there is an excessive VEGF, which will lead on to the abnormal neovascularization, fibrosis and tractional retinal detachment. Now, the most important risk factors are prematurity and low birth weight. In addition to these, the other risk factors include anemia, sepsis, the high exposure to oxygen, especially during the golden hours of life, and then other cardiac defects, history of multiple blood transfusions, and the respiratory distress syndrome. Now, whom to screen? Now, we cannot screen all the babies, so whom do you screen for ROP and when to screen? These are two very important questions. So as per our RBSK guidelines, we have to screen all babies less than 2 kg and any baby less than 34 weeks, and all babies between 34 and 36 weeks with risk factors, a huge list of risk factors as you can see, and any baby who is determined to have high risk, is told to have high risk because of their unstable clinical course by the neonatologist or pediatrician. So these are the babies whom you have to screen for ROP. Now when to screen? The ideal time for screening for ROP is at 4 weeks of birth, as madam said, the 30 din roshne ki. So you have to screen all babies, all preterm babies at 4 weeks of birth. And any infant with a period of gestation less than 28 weeks, they may be seen a little bit earlier because 4 weeks it will be like delayed. So you see them at between second to 3 weeks, second to third week after delivery. Now, how long will you follow up these babies? First is if the retina, till the retina becomes completely vascularized, or if there was an ROP, when the ROP becomes fully regressed and there is no signs of any risk of visual loss. This usually happens between 40 to 42 weeks. So follow up the babies till around 42 weeks if the vascularization has grown and it is okay. And the third one, if the ROP has progressed and you have decided to treat this baby. How frequently can you follow up these babies? Now, if there is no signs of any ROP, it is safe to see these babies every 2 to 3 weeks until the retina is fully vascularized. And if any ROP is present, the important thing is if it is a zone 1 ROP in a stage 1, 2 or 3, without plus disease. If there is plus disease, immediately you are going to treat the baby. But without plus disease, see the baby at least weekly or even a shorter duration. So it is better to see if it is a stage 2 or 3, see the babies every 48 hours or 3 days or something like that as you feel like. Okay, so don't take that risk of not seeing the baby. And if it is in a zone 2 disease with immature vascularization, or it's a stage 1, 2 or 3, then you can follow up the babies weekly or 2 to 3 weekly. Now, this is a recent classification which we have to follow, that is the ICROP3 guidelines. So when you screen a baby, you have to look into all these headings. So you have to classify each eye based on the zone, whether there is a plus disease, what is the stage of the disease, what is the extent of the ROP disease, and whether AROP is present or not. So we go into each of these. So what are the zones which we have to look into? There are 3 zones, as you all know, the zone 1, 2 and 3. And what is zone 1? That is a circle centered at the optic disc, not fovea, at the optic disc, with a radius twice the distance from the disc to the fovea. That is zone 1, the most important. Now zone 2 is a centrifugal extension from the edge of zone 1 up to the nasal ora serrata, and the remaining crescent which is present in the temporal half forms the zone 3. And there is one important point that you have to notice here, that is a zone 2 posterior. What is a zone 2 posterior? It's an area which is 2 disc diameters extending from the border of zone 1 into zone 2. That is a zone 2 posterior disease. And how do you classify the extent of the disease? The extent is determined in clock hours as based on the 12 sectors of the clock hours. So these zones are very important when you are seeing a baby. That is a zone 2 posterior. Now, one important thing that you have to know is what is a notch. Notch is an incursion of ROP lesion of 1 to 2 clock hours into a more posterior zone. Now, suppose you see that a baby is mostly the retina has reached up to the zone 2, but 1 to 2 clock hours of the temporal retina, it is having a notch into the zone 1. Then you have to mark it as zone 1 secondary to notch. Now, this is an important definition that was made by the ICROP. Now, next is plus disease spectrum. Now, what is plus disease? That we are all well aware of, and you should know the criteria when it is called plus. That is, there should be increased venous dilatation and arterial tortuosity of the posterior retinal vessels. When you look at the posterior pole, the posterior retinal vessel should have dilatation and tortuosity, and at least 2 quadrants must be involved, and it may be associated with iris vascular engorgement, a rigid pupil, a non-dilating pupil, or a vitreous haze. Anything less than this has to be classified as pre-plus, and if you suppose you are seeing a baby, there is some arterial tortuosity, some venous dilatation, but it's not meeting the criteria, closely follow up the babies, because there is high chance that this baby will go on to a plus disease. So there is, see, these are 2 pictures of the same fundus. You can see that initially maybe there is a pre-plus slightly, but it has become a plus. Now,
the third thing is what is the stage of acute ROP. So initially we'll see what are the stages 1, 2 and 3. Now stage 1 is a faint demarcation line between the vascular and avascular retina, and stage 2 is a ridge. Stage 3 is extraretinal fibrovascular proliferation, which will be elevated, raised into the vitreous. And this fundus is also showing plus signs. There's a plus disease with a stage 3. Now what is APROP, or recently now we call it as AROP, or the aggressive ROP, which is a rapidly progressive form of ROP with prominence of plus disease. Vascular loops hemorrhages usually occurs in the smallest and most immature infants. And this is sometimes it may be overlooked because of the very feeble presence. We may miss it. So those babies also, if you are suspecting an AROP, you closely watch these babies. And stage 4 and 5, it is like the severe forms of ROP that is associated with retinal detachment, and stage 4A is an extrafoveal ROP and 4B is foveal ROP. And if it is a total retinal detachment, it goes to stage 4. So these are the different stages of ROP. Now how do you manage ROP? There are various methods, that is depending upon the stage. In type 1 ROP, what is type 1 ROP? You have to administer peripheral laser ablation, and type 1 ROP is defined as any stage of ROP with plus disease in zone 1, stage 3 ROP without plus disease in zone 1, and stage 2 or 3 ROP with plus disease in zone 2. So it's better to, this is the time when you decide to treat the baby, and once you have reached this stage, it is immediate laser ablation. Don't delay for any longer period. So you have to plan a laser treatment at the earliest. Anti-VEGF agents are also being used now, especially for AROP as well as stage 3 ROP with plus disease in zone 1. So this is very important. The stage 3 with plus disease in zone 1, you buy time for doing laser. And you also get to see that once you give the anti-VEGF, there will be slightly more improvement in the retinal vasculature. And also you can delay the laser procedure by around 3 to 4 weeks. So by the time the retina would reach up to a zone 2, and so the rest of the retina you can ablate with laser. Two more important headings that we have is regression and reactivation. Regression, it can be complete or incomplete, and there can be a persistent avascular retina, and sometimes the ROP can reactivate, and you have to record it as a reactivated stage 2. So ROP is in preterms, but term babies will have FEVR, and if ROP FEVR-like features seen in preterm babies, you call it ROPA. These are some new terms coined. Now after ROP, we'll just brush through some relevant topics. That is, one is FEVR, which is an, as you know, it's a autosomal dominant condition seen in high myopes. The patients are usually asymptomatic to the extreme. Some patients can develop unexplained, may present to you with unexplained neovascular glaucoma also, children. Now this is a classification characterized by temporal, peripheral avascular retina, and some vascular abnormalities lead on to retinal detachment. Now that is a FFA, that you can see the avascular peripheral retina as well as the macular dragging or ectopia. How do you treat? The treatment is mainly by laser photocoagulation, and in advanced cases may require vitrectomy surgery. Next disease is Coats disease. This is also seen in children. Unilateral, typically presenting with retinal telangiectasis and severe exudations. This also responds well to laser photocoagulation. So you can see that the laser has very well regressed the lesions, and the exudations have also resolved. Another condition called bilateral Coats associated with systemic condition is called Coats plus disease. Lethal condition, it's a severe disease associated with skin condition is incontinentia pigmentosa. It also presents with peripheral avascular retina and telangiectatic vessels, which you may encounter during your screenings. And this condition, we usually in ROP babies, when you screen babies for ROP, you come across this condition, that is a the persistent fetal vasculature, that is incomplete regression of the primary vitreous. It's also typically unilateral. This is seen in full-term infants, usually without systemic conditions. It can be anterior or posterior, And the anterior, as you can see, there will be the leukocoria-like appearance with persistent pupillary membranes, and posterior PFV may be associated usually with a hypoplastic optic disc. Norris disease is a severe phenotype of the spectrum of NDP-related retinopathies, where there can be blindness at birth or in early infancy. You can see the small microphthalmia. The CT also shows the bilateral microphthalmia. Leber's congenital amaurosis, characteristically you get the oculodigital syndrome in this condition, and blindness can happen by 1 year, and there will be a typical extinguished ERG in this condition. This is one common entity that you should know about. Torch infections can present as varying manifestations in the retina. This is the salt and pepper retinopathy. And another relevant condition is ocular toxocariasis that can present as a peripheral or posterior granulomas associated with endophthalmitis, and it will very well respond to albendazole with steroids. Viral uveitis is also not uncommon. And this is the shaken baby syndrome. See, some baby, if you have follow-up coming with multiple retinal hemorrhages and you don't see any particular indication, you cannot, so you have to think about this condition also in our society, in this spirit. So there will be multiple hemorrhages and all. And to end with, I'll just put one slide on retinoblastoma. That's a very relevant topic. I don't have the time to discuss about it. Some points, that is, one is prenatal testing for RB1 mutation. It is very important if the parents are having a family history of retinoblastoma. Super selective intra-arterial chemotherapy with melphalan. It's a frontline standard now. And intravitreal chemotherapy with melphalan will take care of the vitreous seeds. And aqueous humor biopsy will give you the tumor DNA. You can identify the tumor DNA, and targeted radiation. Previously it was the external beam radiotherapy. Now it is a targeted and novel radiation reduces the recurrence as well as the take care of the margin of the lesions. Thank you.
Thank you, Dr. Dhanya, for that very extensive talk. Thank you all.